Good afternoon, hello everyone, and welcome to this very special live event, Overcoming Shoulder Pain, Get Back to Your Normal. Now this event is courtesy of Banner Health. I'm Eric Sperling. I will be your host and moderator today. We have some of the top minds in the field joining us from Banner Health to discuss this very important topic. Dr. Anoo Shah, Dr. Berguson, and Dr. Kade McQuibby, all with us. Excited to have them live in studio. We look forward to chatting with them in just a moment. All right, first, some housekeeping items though, because this is a live stream event. If the stream goes down at any time or you're having connection issues, we recommend just logging off, logging back on. The main thing is this event will be available to stream and share on demand once the show is over. What we'll be doing is we'll be bringing our doctors up one at a time to go over some key items related to shoulder pain and the patient journey, and then we'll have a panel discussion with all of the doctors. So we invite you watching at home to submit questions throughout the show using the chat feature, and we will try to get to as many of those questions as we can. We have a tremendous live audience watching today. For now, let's meet our first doctor.
Hello, my name is Anoo Shah. I'm an orthopedic surgeon specializing in sports medicine, knee and shoulder surgery at Banner Health. So orthopedics has always been a fascinating subject for me. It's one of the few specialties in medicine where we're able to truly restore function in the acute setting, whether it's a fracture or a ligament tear, and even in the chronic setting, such as joint arthritis. So two parts of my practice that I really try to focus on is that I make recommendations to my patients as if they were my family members. And secondly, I try to treat and speak to everyone equally. I think this is a good philosophy to live by in life. I think the best compliment that my team could ever receive from a patient is the referral of families and friends to us, knowing that we genuinely care about their well-being.
All right, magic of TV. You were there on video. You're here live with us in studio. Dr. Shah, welcome to the stage. All right, we're going to begin this discussion talking about some common shoulder issues we see. Again, large audience, very interested in this topic. What are some of those shoulder issues that most of your patients experience?
So there's a few. It really depends on the age of the patient and so forth. So typically in these younger patients, we'll see shoulder dislocations, sometimes some fractures and so forth. In our little bit older patient population, middle-aged and senior citizens and so forth, they may be rotator cuff tears, shoulder arthritis, fractures if there's been a fall.
So you guys see a lot of things. As far as like the more serious shoulder issues you see, what are some of those?
More serious fractures, I would definitely say, and then some shoulder instability. So when someone says, hey, slipped and fell off a ladder and I dislocated my shoulder, a sporting event, if there's been a motor vehicle collision, so some of these fractures. You also have some degenerative conditions like shoulder arthritis that maybe patients didn't even know they had, and then they aggravated in some way, and now it's been really, really painful. So
I was going to ask you about that. Trauma is obvious there, car accidents, sports injury, but what are some of those common causes of shoulder pain that aren't necessarily trauma related?
Most common shoulder pathology is probably rotator cuff tears. Okay. About 80% of these are degenerative, and so just as we age and as we get older, this tendon definitely becomes a little bit thinner over time, and then it can tear from that insertion site. So that's probably the most common. And we're actually seeing a larger and higher incidence of shoulder arthritis. As people are living longer, they were more active for longer periods of time, starting in their youth and even their middle age.
So we're going to be talking a little bit later about how we treat these, how we diagnose some of those injuries. We're going to meet other members of your team, but if you can kind of talk about how the Banner team operates together, how you guys work as a team when diagnosing some of these injuries and then treating these injuries.
This is probably one of the most unique things about our system, which I don't think really exists in the Phoenix area. We have really good integration, and I think that's the key word. So when someone sees, Dr. Berguson, for example, who's going to be on here shortly, if he believes that this patient has some sort of shoulder pathology, he may work them up with an MRI or something else. And once he has that ultimate diagnosis, he has the ability to send it to a surgeon, communicate with us within our electronic medical record system. We've got a great support staff from physical therapists, our athletic trainers, and so forth that can communicate this all under one umbrella so that patient is not lost in the system.
Dr. Shah, great information. Thank you so much. You don't get to leave just yet. Stick around. But for now, it is time to meet our next doctor.
Hello, my name is Dr. Berguson. I'm a primary care sports medicine doctor at Banner Health. Not only did I choose my specialty, but I feel like my specialty chose me. Ever since I was young, I was a multi-sport athlete and loved the atmosphere, and eventually I put my passion towards helping athletes to be able to accomplish their goals, to be able to become their best selves and to be able to compete in the sport that they love the most. I like to sit down and listen to my patients to create a plan that is specific to your needs and your goals. This is built on a foundation of mutual respect, knowing that I will do my best to accomplish your goals and create a plan that is specific to you. Communication is essential to healthcare. Whether it's my medical assistant, my athletic trainer, the physical therapist, or surgeon, each of us are going to be able to work together to make sure that you accomplish the recovery that you need. I would love if the patient would be able to say that I helped them in their recovery, that I was able to answer their questions effectively, and that we were able to get them on the right path in their recovery.
All right, Dr. Berguson, thanks for being here.
Yeah, thanks for having us, Eric.
Okay, I'm going to ask you kind of a broad question here, and I know it's going to be different for a lot of patients, but when should you see a doctor? When should you go see somebody when you have shoulder pain? I know that's tough because there's so many different, but how do you make that decision at all?
A lot of times I'll tell family and friends, because we get this question a lot, is to say if it's affecting your daily life or if you're having trouble doing the things you love to do, come in sooner rather than later, because a lot of times if we catch it early enough, we can prevent a lot of problems from happening so that we don't have to send you to the surgeon here. Like, we love them and we'll use them all the time,
Yeah.
but we want to make sure that we can prevent a lot of stuff. So come earlier. If you have any questions, we're happy to talk to you and help you out.
Are there things patients can do at home to start maybe that self-awareness and, not necessarily self-treatment, but okay, let me practice some things here. It's not getting better. Let me go see a doctor.
Yeah, the first things patients can always do that isn't going to hurt anything or make anything worse is just trying to treat their pain with simple things such as, heat before you go and do stuff, icing afterwards, helping control that. If it's okay and you don't have any medical conditions, maybe trying ibuprofen or Tylenol as recommended. And then even gentle stretching. A lot of times you'll find stuff on YouTube and other places that can do certain exercises, and I always say wait a little bit just in case you make things worse.
Yeah, always cautious, right, of sometimes
Yes.
what you're looking online and, okay, let me try this. As far as diagnosing shoulder injuries, what are you guys using most today? I mean, we still have x-rays, MRIs,
Yeah, we do all of that, but I would like to say, like, hands-on for me is the most important, being able to clinically evaluate you and focus in on what kind of deficits you're having, what kind of pain you're having, where it's at, localizing that. One thing that I kind of use a little bit is diagnostic ultrasound that a lot of physicians don't use, is being able to look at it under ultrasound in the moment you're in motion, because the shoulder joint is very mobile and certain motions can cause that. So being able to evaluate under that can help me too.
Again, another reason why it may not be the best thing to diagnose online. Just self-diagnose, okay, this is what I have, go see a doctor. What are some of those non-operative treatments that are, I guess, still popular, still being used by your team today?
Yeah, first thing, because we talked about that coordination, a lot of times we use the physical therapist to be able to help us to strengthen the rotator cuff muscle to see if we can prevent it. Other things that we can do is just oral medications, or trying to hone in specifically and do injections to specific areas, whether it's in the joint with steroids, whether we use PRP for like the tendons or ligaments.
What's PRP again?
Yeah, protein-rich plasma.
Protein-rich plasma, okay.
Yeah, and I can talk about that. They'll probably have questions later about that. So, but yes, being able to kind of draw your blood, separate it out, get the plasma, the healing factors from your plasma, and inject it around tendons and other things for like ligamentous injuries or tendinous injuries. So.
Okay. Stick around. What we're going to do is we're going to end up shifting, and we're going to, we'll play musical chairs here on set. But first, let's meet our third and final member of our panel discussion today.
My name is Kade McQuibby. I'm an orthopedic surgeon specializing in sports medicine and shoulder surgery at Banner Health. So my interest in sports medicine initially began at a very early age. I was an athlete growing up, and I was exposed to a lot of different athletic injuries. And as I progressed through my medical training, I realized that I had a big passion for helping athletes return to full function. I think what makes my practice unique is I'm very dedicated to understanding the needs of my patients, counseling together with them to achieve their health goals, and then implementing the highest order of science, technology, and new surgical skills to help patients return to function. I think what I would want a patient to say about me after seeing me is that they genuinely felt heard. I would want them to say that Dr. McQuibby was very caring, that he listened, and that he had my best interest at heart.
All right, Dr. McQuibby joining us live on stage right now. And again, I want to thank our live audience for watching. I know we have a tremendous live audience. Remember to use that chat feature at either the bottom of your screen or the side of your screen if you have any questions. I know our doctors are delivering some great information up here, so please use that chat feature, and we'll try to get to as many of those questions as possible. Just out of curiosity, because you mentioned it, what sports did you play?
So I grew up playing a lot of baseball.
Okay. Where at?
And then, so I grew up just north of Portland, Oregon, Vancouver, Washington. We had a good team up there growing up, and I was lucky enough to get out there and play a little bit in college too, and yeah, I played some football too. So stayed active and still continue to play, pickleball and some of the more, sports that the older guys play.
Did you ever get into competitive events with these guys? Because I know they're
not yet.
Okay.
No, but
right. Maybe it starts here.
Actually, Dr. Berguson and I, we have a clinic together, so we've talked about getting out and playing a little bit of pickleball.
Well,
so
don't play hoop with Dr. Shaw.
Yeah,
he's pretty serious on the basketball.
Believe that. Long time ago.
Let's talk about some surgical options now. As we get into surgery here, what are some advancements in care? I think one of the questions we always want to know is, how have things changed over the years when it comes to shoulder surgery? Are we still talking about things we did 10, 15 years ago, or have we seen a lot of advancements in care for some of those specific surgeries?
No, there's been a lot of advancements in care, especially in the last 5-10 years.
Okay.
And that's the exciting thing about sports medicine, is it's an ever-evolving field with a lot of opportunities for biologics, a lot of new implants.
Biologics,
a lot of new
I'm sorry, what's biologics?
Yeah, so biologics, Dr. Berguson talked a little bit about PRP.
Okay.
And then there's some other, biologic stem cells as well, that there's a lot of work being done in that field. And then, just surgical techniques that are a little bit more invasive or less invasive than they have been in the past. And, it's an ever-evolving field with new techniques and new options to treat a lot of these pathologies that we've discussed previously here.
So with those less invasive techniques, I know probably one of the top questions you get from patients is always on recovery. Yeah. And we know shoulder surgery can typically be a longer recovery time. So let's talk about that. What do you tell patients when their first question is, okay, what's my recovery going to look like? And again, I know surgeries are different for everybody, but what's my recovery?
No, I think you're right. I think shoulder surgery has a little bit more of a reputation of being a difficult recovery, and I think that's true in certain cases. But a lot of it depends on why you're having surgery in the first place. So, rotator cuff repair surgery technically is a little bit more difficult recovery, but we have really good resources with our physical therapy through Banner, a lot of visits, and then ability to cooperate within the department itself to try to help patients along in that recovery. And then, rotator cuff repair, again, we mentioned that, but shoulder replacements tend not to be quite as difficult, but
Is that new, shoulder replacements? Is that relatively new, or has that been around for a while?
Yeah, so there's a new style of shoulder replacement. It's the reverse shoulder replacement, and that's relatively new within the last 20 years, and that has expanding indications that have, originally it came out for a single purpose, and now the indications have expanded to other indications such as fracture and other things. So it's becoming much more common, but it is relatively new.
I mean, we hear about knee replacements all the time, and then when you hear shoulder replacement, okay, wow, that's interesting, and that's again relatively new. Back to sort of the recovery thing. Let's talk about rotator cuff for a minute, because in your opinion, why do so many people experience rotator cuff injuries, and then what's the recovery like for that?
Yeah, I think there's a couple of reasons. First off, I think the shoulder joints specifically is a more difficult joint because of its mobility. So out of every joint we have in our body, I think the shoulder is by far the most mobile, and then so we have to balance mobility with function and stability, right? And so there's a lot of different ligaments, a lot of different muscles that provide stability to the shoulder, and that raises a lot of opportunity for certain structures to become damaged. But I think the reason that we see most commonly is, again, as Dr. Shaw had mentioned previously, is more of the degenerative type changes in the shoulder. Yeah. We have an aging population that's trying to stay active, which I think is a great thing, and that's our job, is to keep everyone continuing to be active, whether that's playing golf, playing pickleball, doing the things that they like to do in life. And so as that aging population continues to be active, sometimes our body just, can't keep up with our will sometimes.
Right. All right, well, it's the time of the program where we're going to start taking some of those live questions. And again, we have a tremendous live audience watching. We want to thank you for those questions. And how this is going to work, I'm going to read some of these, Cole, but we have a fantastic team from Banner Health here moderating some of these questions. And so as they come in, I will read them, and then you guys can kind of, whoever wants to take it can take it. But it'd be nice to get, different opinions here. I'm going to ask the first question here. Why is there a painful stuck feeling when reaching across the body? It's not like Jeopardy.
Yeah.
Just go for it.
I mean, that can be a multiple reasons why. And a lot of times with the shoulder, like we talked about, it's a very complex joint. And so it can be multiple different factors causing that. So whenever I hear kind of getting stuck, specifically with certain motions, usually it's caused, well, most often with a discoordination between kind of the shoulder blade, that foundation of the joint, and the ball and socket joint itself. So is it because of the bones, like you may have a fractured piece in there? Is it a calcification within the tendon? The labrum getting stuck? There can be multiple reasons why, and a lot of times that physical exam is super important. So
I think just as Dr. Berguson said, I think there could be a number of reasons, but probably the most common reason I see is when they feel something get stuck is a loose body. And so almost like you have a pebble in your shoe, when you're walking, you can feel something catch or roll around. That's typically the most common one that I would see from a surgical setting. McQuibby, please correct me if I'm wrong. And then the other one might be a little bit of arthritis, where maybe a bone spur or something is catching on a capsule or something like that.
Okay.
Yeah, couldn't agree more.
Okay, perfect. We got a lot of questions to get to, so that was perfect. Cortisone shots. Sometimes it says, why don't cortisone shots always work? And I think maybe that's for everything. Not everything always works, but why don't cortisone shots always work?
Yeah, I think that's a tough question. I think it depends on a couple of different factors. I think the type of disease that you're presenting with, some types of disease are a little bit more responsive to cortisone injections. In addition, I think how advanced your disease is as well. So I know we've talked a little bit about degenerative changes in the shoulder arthritis. And I think in mild to moderate osteoarthritis of the shoulder joint, these patients tend to respond a little bit better than the patients who are advanced down this spectrum of arthritis in the shoulder. And as the further down you get to the more advanced side, patients tend to respond a little bit less to the corticosteroid injection. And the same thing goes with rotator cuffs as well. If you do have a full thickness tear, this is a structural problem where a tendon is not attached to bone. And magically, an injection of fluid isn't going to reattach that tendon back down to bone. And so I think, structural problems sometimes require structural solutions, which is a surgery, but oftentimes that's not the case. And, there are patients that, maybe have a partial thickness tear, maybe have some fraying of their rotator cuff tendon, and they tend to respond favorably to cortisone injections.
So you've been talking about arthritis, and we just had a question come in, and we talked about diagnosis. How is arthritis diagnosed? How do you guys diagnose arthritis?
I mean, a lot of times we start with an x-ray because we can see changes within that bone structure that can help us hone in on what it is. Whether it's a little bone spur, for instance, in the thing, or the joint is starting to kind of collapse a little bit and there's some changes in the bone, some irritation or edema, swelling within the bone, like a bone bruise. So that's probably the first step we would take to kind of diagnose.
What's the patient's reaction when you guys tell them it's arthritis? Is it I'm curious, is it doom and gloom? Is it, okay, this is very treatable? What is the typical patient reaction? Okay, you have shoulder arthritis.
It's a wide variety.
I would say in my patient population, some is disbelief, especially if it's a middle-aged person, like, well, how come it wasn't symptomatic, and why do I have arthritis now? I think if it's in an older population, 70, 80, there's a little bit more acceptance. I think probably the biggest surprise that patients have is when they've been living with arthritis that has been asymptomatic and then something triggered it. Maybe they overdid something, maybe there was an injury, and it's just more of a disbelief. But I think for the most part, patients that are older than 70, 80, they typically understand, hey, joints are wearing out. Those x-rays actually do us wonders in the clinic because people can actually see what a normal shoulder looks like, and then they can see the joint space narrowing, the bone spurs that are evident on x-rays.
You mentioned being a baseball player.
Yeah.
So do you see, ex-athletes coming in an earlier age? We're talking about being in your 70s or 80s, but somebody coming in their 30s and 40s who, was a pitcher and they've got shoulder. So is there anything more common I was an athlete in high school or in college, and arthritis is more common?
I think less common than baseball players or overhead athletes. I think oftentimes in a younger population that kind of presents with this disbelief, wait, I have shoulder arthritis?
Yeah.
It usually tends to be, you know, the guy in their early 40s who's been a power lifter, who's really stressing their ball and socket joint with, you know, heavy overhead lifting that's been repetitive, and they're doing it at a competitive level, and finally it just, you know, the wear and tear catches up to them a little bit. And so that's probably in a younger population when I see osteoarthritis most.
I do want to get to some pre-submitted questions, because in addition to these great live questions come in, we had the audience pre-submit some questions. So I'm just going to ask again, you guys can answer if you will. How can your sleep position affect your shoulder? We've talked before on previous webinars about side sleepers, back sleepers. How can your sleep position affect shoulder?
Hey, I'll take this one. Yeah,
we always kind of zero in on you.
That's great. Yeah, I'm in the middle.
You made eye contact.
Yeah. So I think sleep position, it usually doesn't cause problems more often than not, but it can definitely exacerbate the pain and discomfort. So for instance, if you hurt your shoulder and you're more of a side sleeper, you lay on that side, a lot of times that can just make it worse or not help it heal as quickly. Or if you kind of have your arm up in a position where it kind of can pinch certain tendons and muscles and bursa, that can also decrease the time or increase the time it takes to heal.
Okay.
Yeah, so definitely affects it, but usually doesn't cause it.
One of the questions here, because you were talking about power lifters, let's not talk about power lifters, but just somebody going to the gym a few times a week. Should you continue exercising if you're experiencing shoulder pain? I mean, sometimes, okay, I'm just sore from exercising. What point do we say, okay, we should probably stop exercising?
Yeah, I think you made an important distinction. I think soreness is different from acute pain, right? And so I think listen to your body, and people who have been in the gym, I think, know the sensation of soreness, which is, you know, a good thing sometimes, that we're building up muscle and we're becoming stronger. But, you know, I would be worried or pump the brakes a little bit on these exercises when you're feeling acute pain that's limiting your function, limiting your strength, and limiting your range of motion. And in these patients, I often, you know, counsel them to try to avoid heavy overhead lifting, and just as a general rule, you know, try to cut back on the exercises where you can't see the back of your hand. So for example, military press above your head, or lat pull downs behind your head, that sort of thing. So as a general rule, I found to tell patients, you know, if you can see the back of your hand, generally, it's, you know, it tends to offload the shoulder a little bit more than
That's great
other
tip. Yeah, I like that one. Okay, more live questions coming in. If I'm experiencing shoulder pain, should I go to my primary care doctor, or can I go straight to an orthopedic doctor? Great question.
I'll take this one. I think here at Banner, we do a really good job of getting most patients to our primary care sports docs that can help take care of a lot of these non-operative problems, because Dr. McQuibby and myself, as orthopedic surgeons, the vast majority of our patients that we see in the clinic, we're not signing up for surgery, and they don't have surgical indications. A lot of these are non-operative. And when you've got a non-operative guy that's in the clinic way more than we are, I think they are definitely the best people and the most educated people to have that conversation and have that discussion with the patient. So I think within our system, I think the best person to see is somebody like Dr. Berguson, a primary care sports doctor. If for whatever reason you can't get into them, I think, you know, Dr. McQuibby and I would be happy to see you. We're good at this, we enjoy it, but part of this integrated system is probably what sets us apart.
Fantastic. And I believe we do have the link set up in the chat, so if you are interested in making an appointment, there's a link there to set up an appointment with someone like yourself.
Perfect.
It's technology. Okay, kind of a broad question here. What's the best way to prevent surgery?
I'll take this one. I know all of you guys can do it, but so surgery prevention is a lot of times starting with the mechanics of how you do certain activities. We talked about a lot of overuse injuries like chronic rotator cuff injuries, degenerative changes. Prevention is one, just being active, but doing appropriate activity. If you feel that you're having pain, once again, like Dr. McQuibby talked about, avoid that pain and check yourself to say, okay, am I doing a good posture when I'm lifting? Am I exercising? The other thing is, don't jump into something too quickly. A lot of times we get the weekend warriors. I just had a patient come in and he wanted to scrub his pool, And so he did it for an hour and a half, and he scrubbed that pool, and then afterwards was having some shoulder pain. And so I was able to talk to him a little bit about, okay, this is why, and get him into a team that could really help him and get him going.
You brought up something, and I hope we can expand on this. Activities that we didn't necessarily think would be causing shoulder. What are some of those things that you guys see? And again, we have the, like you said, the basketball, the lifting, but I know people who've had shoulder injuries from scrubbing the pool. What are things in Arizona that you guys have seen that sends a patient your way? Maybe that's a little outside of the box.
Oh man, I can't think of any specific thing, specific to Arizona that comes to mind. But I'll echo what Dr. Berguson says. It's a lot of the repetitive overhead type activity that I see commonly that can irritate your rotator cuff and bring patients into the clinic with repetitive overhead activity. Usually is what I see.
I think just to piggyback off at those, I think it's when someone hasn't been performing these exercises or this motion with that much strength, that much velocity over and over again, and you're not used to it, it's going to be natural that you're going to be sore. It's kind of like if you're not a runner and you decide to go run 2 miles, you're going to hurt the next day.
Yeah.
That's just very natural. And so this example of somebody scrubbing the pool, not that they've not scrubbed their pool, but maybe they just overdid it that day, and those muscles that are all responsible for having the shoulder work biomechanically really well, they weren't used to it and they took a tremendous hit, so now it's just going to take time to get better.
I've just heard that a couple times in recent years. Oh, what were we doing? I was scrubbing my pool and shoulder. Oh, interesting.
Maybe that's specific to Arizona.
There you go.
That may be specific to Arizona.
What about things like golf and pickleball, like things that are very common here in our state?
Yeah, we see a lot of patients that come in with that, whether they've been doing it for a long time and they still want to compete at a level that they used to be able to compete and can't quite maintain that for as long.
Okay.
So a lot of times it's taking a step back, just going twice a week instead of 7 days a week, just for a little while until they can build that strength back up or change how they hit and what they do.
And again, thank you to our live audience. Keep those questions coming in. We've got a few more here. All right, this is a good one. What are the chances of re-tearing your rotator cuff after surgery?
So there's always a chance. I would say that most rotator cuff repairs that we do very well, and even some that actually do re-tear. And so the reason being is that when we repair a rotator cuff tendon, what we're really hoping is that there's this good scar interface between the tendon and the bone. And so we drill, we use these anchors, we have these fancy techniques to get that tendon back down, but nothing is really as good as what you were born with. And so there is a certain failure rate, and if you look in the literature, this is all over the place. It could range from 10% to 30% to 40%. But that doesn't mean that you're going to be symptomatic just because it fails.
Right.
And so most people actually do quite well. I would say 80 to 90% of people that have a rotator cuff repair, regardless of if they failed or not, are actually doing better than they did preoperatively.
What is typically recovery time for rotator cuff?
Yeah, it's again, I always tell my patients that rotator cuff repair is more of a marathon than it is a race, and this tends to be a little bit more one of the difficult recoveries of the shoulder surgeries that we do. But usually at about 3 months, that's when patients are able to get back to strengthening their rotator cuff and optimizing their mechanics again. But usually I'll tell patients about the 6 month to a year mark. That's kind of when they'll stop thinking about their rotator cuff repair, and it won't be on their mind continuously.
We've been talking on the show about non-operative treatments. Question coming in, maybe fact or myth here. Can cortisone shots cause damage to the joint?
Yeah, I'll educate a lot of my patients because a lot of patients have this question. Repetitive steroid injections, it's foreign to the body, so in general, it can cause some irritation. I wouldn't say damage, that's kind of a strong word, more of an irritation. And a lot of times it's not really the steroid causing it, but the people feel better and start doing more. And so it's the arthritis progressing and the steroid not being as effective as we kind of do those repetitive injections. So I would kind of focus more on that, that side of it.
I think in my practice, in patients that present with a rotator cuff injury or rotator cuff pathology, I usually one is kind of the treatment for me. If you talk me into it, maybe I'll do 2. And I think the reason why is I think most of this data comes from animal studies where, you know, there could be some evidence of collagen weakening in your rotator cuff after 2 steroid injections. And this is pretty specific to surgical literature as well, where, you know, if you do get corticosteroid injections more than 2 prior to a rotator cuff repair, for example, if these cortisone injections don't work long term, then you do have a slightly higher rate of failing to heal that rotator cuff repair if you get more than 2 corticosteroid injections prior to your repair. So there's some literature out there, but I think, you know, we're still learning. And again, you know, orthopedic sports medicine and primary care sports medicine is an ever evolving field, and we're learning every day.
I think just one thing to piggyback off that is that one of the beauties about the shoulder is that there's multiple compartments. So when we get a steroid injection in the knee, it doesn't matter if you inject it on the front, the side, wherever, it all goes to the same spot. And so Dr. McQuibby is talking about rotator cuff tears, and so typically when we inject that, we put it in one space above the tendon. If we're talking about arthritis and we're treating this for arthritis, we're putting it inside the joint. And so that's where the number of steroid injections may play a role, the duration of how often we're giving them, and so forth. So steroid injections, theoretically, yes, they are irritating and can cause damage with repetitive injections and, you know, more frequent use of these, but sometimes we'll use them as a diagnostic tool. And so just getting them a 1 injection is probably not going to cause significant damage.
Okay. Speaking of non-operative treatments, question just came in, and we talked a little bit about it earlier, but love for you to go a little more in depth here. Explain PRP to us.
Yeah.
And in a way that I can understand.
Yeah, no, that's great. So our blood naturally has anti-inflammatory factors in it. Whenever you injure yourself, the blood flow increases to that injury. And so what we're doing is trying to facilitate it and trying to get some of those healing factors specifically into where the area is you're having pain. So we draw your blood, we spin it down and separate the plasma from the red blood cells. The plasma has all those healing factors in it. And then we take that plasma, and I usually use, when I'm doing PRP, I like to use ultrasound to make sure I'm getting it exactly where it needs to be. And I kind of guide that needle into the bursa, around the tendon more often than not. Every once in a while, we've tried it with arthritis, and some patients can have benefit with that too. And so guiding that in there to help decrease the inflammation, facilitate healing a little more quickly.
Okay. You guys agree? Like, that made sense?
Yeah, that's great.
He's really the expert on PRP, biologics, and so forth. So we typically defer to our primary care sports guys on that.
I get it. Great. Okay. I like this one. Pain in the collarbone. Can pain in the collarbone be related to the shoulder? So is that your area of expertise? Like, are we still talking about the shoulder here in the collarbone?
So I know we get this all the time. So the collarbone is the clavicle, right? It goes from here to here, and it's really responsible for 2 joints. The one in the near your sternum called the sternoclavicular. Most commonly, when we're talking about the shoulder, while there are pathologies here, pretty rare, it's really the AC joint. And so the AC joint, you can have an AC joint separation, you can have AC joint arthritis, you can have a fracture of the clavicle. So those are the ones that people are typically talking about. You have a big muscle, your pectoralis major, your pec, that attaches to it too. And so sometimes you can see some irritations of the pec insertion site right on the collarbone. And that sometimes we'll see in weightlifters or people that do repetitive overhead activities. Okay. But those are probably the most common ones that I see.
Yeah,
I don't know if you're seeing anything else.
I agree. And oftentimes, I think the majority of patients who I'll see in my clinic are the AC joint or the acromioclavicular joint irritation. And, you know, it's common, again, in patients, repetitive overhead activity, power lifters, and it's usually, you know, tenderness to palpation right over that bump kind of on the end of your collarbone. So that can definitely be a contributing factor to shoulder discomfort and your shoulder mechanics.
So any chance I get an opportunity to talk about my tragic high school football career, I will do it as well. So broken collarbone, and again, we were talking about ex-athletes, certain injuries, and you know, dirt bikes, you know, a lot of clavicle injuries related to contact sports. Is that something that definitely has an impact on the shoulder later on in life if you experienced, say, a broken collarbone, teens, early 20s during your athletic career?
You know, I haven't heard any definitive, definitive data when it comes to that. But I think all of our soft tissues are tensioned in a specific way. And, you know, I always tell patients that the shoulder is kind of an orchestra, right? And there's so many contributing factors, like the collarbone that attaches to your shoulder blade. We have 17 muscles attaching to our shoulder blade. We have multiple ligaments. And sometimes, you know, if bring it back to the orchestra or the symphony, if the violin's too strong, it doesn't sound right.
Yeah.
If, you know, whatever instrument you want to choose, right? So again, it's a very, you know, it's a very I don't know, things have to be working in concert in order for your shoulder to function. And so
that collarbone injury can
potentially
mess with that orchestra. Yeah, it could be a mistuned instrument. Bone spurs question coming in. How are bone spurs related to your shoulder? How are they fixed? Because I know you guys mentioned bone spurs earlier. You mentioned that a few times.
So typically when we talk about bone spurs, we're talking about shoulder arthritis. That's what happens when bone rubs on another bone. So when the joint space is really narrow, bone is not very bright typically, and it just puts down more bone. So that's really the etiology or the cause of a bone spur. In order to treat something like this, depending on the severity of the arthritis, typically it's a shoulder replacement. Very rarely, and maybe in some specific indications, you can go and resect that as long as the joint space is maintained, but that's pretty uncommon. So typically it's a shoulder replacement. Another area that I know we see a lot of times is people will say, oh, my bone spur was removed when they repaired my rotator cuff. And that really just means that a part of the bone was shaved, and it's a different part. It's the acromion, where they maybe just decompressed that area so that there was a little bit of breathing room for the rotator cuff. Okay. Not really a bone spur, just basically normal anatomy or the anatomy of that patient that was removed a little bit just to create some breathing room.
Okay, how can you identify a frozen shoulder? What are causes, treatments? What is recovery like?
All right, I get a few referrals every week for this. Yeah, so frozen shoulder, the main way that we kind of diagnose this is you have your limited range of motion first, and it's both active, what we call them, patient doing it themselves, and then passive when we lift it and they just can't go. So we get to 90 degrees or maybe even a little less, and it just won't go with us lifting it and them relaxing.
So that's a frozen shoulder.
That is a frozen shoulder. It's not necessarily just when they do it. So once we get to that point, there's a few different options that we have. A lot of times this will heal on its own over time, but it usually takes a year to go through the different phases in general. Some people a little faster, some people a little more. But we're coming up with new techniques to where we don't necessarily have to do surgery, depend on the surgeons to do that. So we do something, just normal steroid injections to kind of decrease the swelling and inflammation so that you can then stretch it. Stretching is the one thing that'll be able to get that motion a little bit back sooner. Other things are controlling your other chronic conditions like diabetes, thyroid issues, to get those under control to kind of optimize the healing in that. The next one is what we call a hydrodilation, is where we inject saline into the joint and kind of expand that capsule a little bit so then you can move a little more so that you can keep that motion going. And all those things, if those don't work, then yes, there is, manipulation under anesthesia where we take you back, put you to sleep, and we just move it for you.
Wow.
Which it's a hard recovery and it's a hard diagnosis to have, but there's options to be able to get you a little more motion until the body's able to say, okay, we're done.
Right.
And heal.
Okay, a lot of options there for frozen shoulder. All right, this is a fun one. Can you demonstrate some shoulder strengthening exercises? You guys are all mic'd up. Do not get off the couch. But can you mention just some strengthening exercises?
So typically they're band exercises. So when we look at the shoulder exercises, we're thinking about the rotator cuff and scapular stabilizers.
Okay.
And so the scapula is that little winged shaped bone on the back of your on your back, which Dr. McQuibby showed or basically said there's numerous muscles that attach to it. And so I love the orchestra example. I use the same one.
Yeah.
And so you want everything to fire in sync, because when we move our shoulder, 60% is coming from the ball and the saucer, and then about 30 to 35% is coming from that wing, that shoulder blade moving over. So even if we fuse the main shoulder joint, we'll still have motion.
Okay.
So we really want to optimize all of those. And so probably the best one for your rotator cuff are the different band exercises, and these are all found in different sites online, and then our band or physical therapist can provide a good home exercise program. It's really attaching a band to the end of a door handle or something that's stationary, and then performing some gentle external rotation ones. You can do it with the cables at a gym and so forth. Forward flexion, that one can help a little bit, but primarily external rotation. That's the biggest one that we want to focus on. And then seated and upright rows, primarily seated because the upright rows are going to get more of the trap, but really getting there and bringing your shoulder blades back together, bringing both of your shoulders to try and touch if you can. Those are probably the best exercises, I think, for your shoulder.
Okay, great. Yeah, you didn't get
Do you
up or
have
anything.
anything to
No, I agree. I think there's a lot of good resources available. Probably some through Banner Health's website too, but reputable orthopedic. I know the American Academy of Orthopedic Surgery on their ortho info site has some good exercises as well, and I often will refer to patients them to those sites for some future
Added,
exercises.
yeah.
Yeah, exactly. Yeah.
So let's touch on some of the things we talked about earlier and how imaging is used to diagnose, because you mentioned ultrasound. It seems like there's so many different things that can occur with the shoulder. So how are some of those different imaging resources you guys have used to diagnose those specific injuries?
Yeah, I think X-ray is more geared towards or focused on bones in general. We don't
Okay.
see a lot of the soft tissue. So then we depend on other imaging like the MRI to look at the tendons, the muscles, the bursas, and the ligaments to really, and even the labrum, for instance, to be able to see what it looks like. And sometimes we also have to inject dye with the MRI to look at specific labrums. So those are probably the two most common used. The ultrasound is less invasive, and just less costly in general, but it's hard to diagnose deep tissue. So a lot of times we can't do that for everything, but we use it when we can.
So really X-ray, MRI are
Probably the two most common.
okay, got it. Love this question here. What do surgeons do to stay current when it comes to advancements in care? Because we've been talking about how things have changed over the last 5 to 10 years. What do you guys do to stay current and always be ahead of the game when it comes to shoulder care?
So, like in most professions, there's medical education, and so continuing medical education, so CME, we have different meetings at different locations for different specialties. For example, our main one is our American Academy of Orthopedic Surgeons meeting. That's typically every March, and so we'll attend those. And then they have specialty-specific meetings, so I tend to attend most of the shoulder ones, nationally and internationally, and then some of the sport ones. Through these meetings, we learn different techniques, and so you talked about imaging, for example. So when it comes to shoulder replacement, pretty much most shoulder surgeons will get a CT scan to plan a certain case, because this way we actually understand your anatomy. We can plan where we're going to put our components to the length of the screw, which is actually very impressive. We'll get MRIs.
Why is that really impressive? What is that?
What's that?
The length of the screw, like getting it down to...
Because that's how accurate we can get to.
Okay.
And so we've been able to compare our preoperative planning with the actual screws that we're using at the time of surgery, and they match.
Okay.
And so that's just been a huge elevation and advancement in imaging for a joint. I think the other part is MRI. We can really tell with some certainty, which rotator cuff tears may be repairable and which ones aren't. And then I think through research, just staying up to date with the literature, we have numerous journals that all of us tend to read, and they're specialty specific as well.
Fantastic.
I will say one thing really quick. So I actually trained around Dr. Shaw here, and it was really cool because every week we have just a little meeting, an hour in the morning, where we can share different insights and articles that we read, and we try to stay up to date quite often, and I learned a ton from these guys, so it was fun.
So as we wind down here, a couple of last questions. Should I seek care if I experience shoulder pain at night, but it goes away once I'm awake and moving in the morning?
I think if it's significantly limiting your ability to get good rest, I think sleep and recovery is very important. And I think, if you're waking up the next day and you're really struggling because you can't sleep well, I would definitely seek additional opinion from a care provider.
Another common question right here. What's your opinion on deep tissue massage, chiropractic care to alleviate shoulder pain? We've been talking about these different kind of techniques, non-operative techniques. It's a little different. Massage, chiropractic care. What are your opinions on that?
I have the opinion that everybody has a place at the table, but it's also coordinating care with each other.
Yeah.
Because chiropractors do a lot of good manipulation and other things, and they're trained in that. Deep tissue massage physical therapists, they can also really help the muscles and strengthen and stretch certain things. And so I just say it's a different approach to healing, and a lot of times it's helpful to get these people involved. The problem is a lot of times we're not coordinating as well as we should, and so a lot of times we're tripping over each other as we're trying to help the patient. We're all trying to do the best thing we can for you, but utilizing a lot of different people can be good for specific injuries. I will say that there's some things that may not get better.
Right.
Is it necessarily going to hurt you? No.
Right. So as we wrap up this conversation, again, I just want to thank our live audience so much. Tremendous questions coming in, great information, but I want to give each of you an opportunity. We talked about how you're educating, how you're staying in front of the game. What are some of the things you're most excited about when it comes to advancements in care? Whether it's something you're learning, something you're experiencing with your patients. Dr. Shaw, I'll start with you. Just what are some of the more exciting things that are top of mind for you as patients are watching this, and maybe not just for themselves, but information for their family members too that are going through shoulder pain or needs shoulder care? What are you most excited about?
For me, the most exciting thing is we have been able to educate more and more people on the myths of shoulder surgery.
Yeah.
More often, we always hear about the negatives, and if you turn on the local news, we were chatting about it, you always hear about the bad. And there is so much good that comes from shoulder surgery. We see it. I mean, we wouldn't be performing these procedures if 90% of our patients did poorly, but unfortunately, it's the 1 out of 100 that someone hears that, oh, they had a shoulder replacement and they were never able to lift their arm again. And so I think this educational component that we're able to do, in addition to the advancements in technology to make us better, to make us more accurate, to have increased healing rates with biologics and so forth, that's what really gets me going, is that if we can really continue to educate patients that, hey, rotator cuff repairs, it is a marathon recovery, but 6 to 9 months later, you should be pretty good.
Yeah.
Hey, we did a shoulder replacement on someone, and 90+% of the time they're going to do very well. So as long as we can kind of demyth, if you will, some of these false perceptions that I think the patients have, I think that's the best part of it.
That's what opportunities like this are for. All right, Dr. Berguson, what are you excited about?
Honestly, the first thing that came to mind when you said that was just being able to work with a team that was really coordinated and helpful. Because, I'm conservative in my nature, but a lot of times I want them to go talk to the surgeon to say, hey, no, this is something that can help. And I trust these guys a lot, and being able to coordinate that. That being said, inside medicine, what I'm excited about is just the orthobiologics and other things that are coming out that can really help decrease or prevent a lot of problems further on. And then, being able to get you guys back on your feet, because that's what our goal is, honestly, is to get everybody back to what they want to do. We're not here to prevent you from doing it, which a lot of times we think, and we have to for a little bit, but in the end, the goal is to really get you going again.
Hope all of us watching have like a good grasp of what orthobiologics are now. It just sounds good. We can impress our friends at the dinner table. You're having shoulder pain? Let's talk about orthobiologics. All right, Dr. McQuibby, bring us home here. What are you excited about?
To bring up orthobiologics again. Honestly, it's a really cool field, and I think there's a lot of good that's going to come out of it. I think there's still a lot of work that needs to be done. And as we tailor in our indications for each specific orthobiologic, this condition's good with PRP, this one maybe not so much, this one may be good with another. I think that's really, it's a bright future ahead of us in our literature with regards to sports medicine and shoulder surgery. I'll echo what Dr. Shaw said too. I really think the new technology that's coming out in planning shoulder replacements is really cool. So that preoperative CT scan that we get allows us to match component size specifically to patient anatomy, match their bone size almost perfectly, again, down to the size of the screws that we're putting in. And then also the software allows us to, position the components, do the surgery basically virtually before we get in there and do it physically, which I think, is a big help to, put these components in the correct position to optimize range of motion and function. And the software allows us to do that. I think in the future too, there's going to be opportunities for robotic type shoulder replacements or virtually assisted shoulder replacements intraoperatively, which will be cool too. But that's a few years out, but definitely on the horizon. It makes me excited.
I want to thank each of you for your time. I know it's hard to get all of you in one place at one time, so tremendous thank you to you. I want to thank Sarah and Sierra from the Banner marketing team, because I know they had a ton of questions coming in. They did a great job filtering those questions, making sure we got to as many of those questions as possible. And also a reminder, we did talk about it earlier. If you're interested in making an appointment, we do have a link for you in the chat there. The goal, again, is to seek a primary care physician first, and then you guys can kind of determine that patient journey for them. Again, that link is in the chat for you. And thank you so much for watching. As a reminder, this will be available to stream and share with those you will find, that you'll know will find this information valuable. Again, shoulder pain, so many people that are in our circles deal with shoulder pain. So if you are watching this, use that link after the show, send it to somebody that you know will find the information valuable. Thank you for watching, and we will see you next time.